Hi, everyone, and welcome back. I am here with Dr. LaVerene Garner. I call her Lava, so, but I want to introduce her to you first. She wrote the neurology chapter in the book that Dr. Joe Tata and myself edited and contributed to, Integrative and Lifestyle Medicine in Physical Therapy. And so Dr. Garner is a board certified neurological clinical specialist. And currently, she's an assistant professor in the Department of Physical Therapy at Winston-Salem State University here in North Carolina. Prior to her role as professor, Dr. Garner developed the vestibular therapy, mindfulness, and integrated health components of a concussion recovery clinic at Camp Lajune in North Carolina, where she treated individuals with chronic neurologic conditions. And if I was saying it correctly, I suppose it should be Camp Lejeune. So I will correct myself on that. Welcome, Dr. Garner.
Thanks. It's good to be with you.
Yeah, same here. As much as we know, we're not related, but we're not sure. So
That's right. Our
just
yes, my husband's from close to your family.
so we
So
figure we probably are in some way.
yeah, maybe distantly.
Yeah, maybe distantly because our families have been here in the same area of the state for a few hundred years. So
Yeah.
it's probably highly likely. But speaking of that, speaking of family and history and such, tell me a little bit about yourself and what led you to PT.
Yeah. So I was born in ultra rural Kansas, and then we moved to what I would consider rural Indiana when I was in first grade. And so I grew up in very rural communities where I didn't really realize there were big problems with access to care until really much later in life. I just didn't consider it, but that was a big part of my lived experience as a child, was not having loads of access to really high quality care. And so anyhow, when I went to college my freshman year, I was having headaches from studying, and one of my friends, she worked on my neck. She did suboccipital release, and I thought it was so cool. And I didn't know how she knew how to do it, but her mom was a PT, and so her mom had taught her how. And so I became really fascinated by just the technique she demonstrated or showed as a freshman in college, I guess, who's untrained. And I decided I would go home and start volunteering and so that I could learn more about physical therapy. And my mom was a nurse at the hospital. So she got me set up and I started observing, and I thought it was the coolest thing ever. And so that really is what set me on my trajectory, I think, to become a PT.
Wow. Yeah. Well, I mean, of course, I think PT is pretty cool and pretty fun as a career. And it takes on, many different PTs are working in all kinds of different forms now. Thankfully, we're seeing PTs branch out into not just management or administration, but things like public health. And what is what I am fascinated by, since I come from the orthopedic sports medicine to orthopedic to pelvic health kind of journey from my side, is I was never, neurology was never, other than what you had to take, right, in PT school. When I did my neurological rotation, it was never on, on the forefront of my career path for me. So I'm wondering how you came to focus on neurology.
Huh. Well, I think it was a happy accident. I would say, really, I'm a generalist. I started out in an orthopedic. My first job was in orthopedics, but I got certified in Pilates. And so that really led me to the breath, which I'll talk maybe more about later. But when I first learned about the breath, I thought it was a bunch of mumbo jumbo. I was like, I am never going to use this. And who knew? But that's what the young 22-year-old or 24-year-old, however I was when I
Yeah.
got out of PT school, thought. So anyhow, I ended up moving back to North Carolina and worked in a job setting where we rotated. And I ended up in outpatient neuro and I loved it. And then I moved to Jacksonville, North Carolina, and ended up being the only person in town that was really available to treat people with vestibular problems. And so all of these Marines started coming back from the war with an sundry of symptoms. And so I oftentimes was treating 18 injured Marines a day out in
Wow.
town, and then eventually moved to Camp Lajune to work. So I think that I'm grateful for my background as a generalist because it gave me the ability to treat numerous impairments simultaneously, which is necessary in that population of people. But it also really helped me that in my role now where I teach to be less siloed and to understand how beautiful healthcare can be when we understand a world or entertain a world outside of our own, when we get out of our comfort zone and really start to learn more about orthopedics. Or even in the military population, the pelvic floor is often a problem. Pelvic health is often an issue in the male Marines that I worked with at Camp Lajune.
Mm. I think you said something that's really important that I just want to draw out, and that was um, your experience as a generalist really suiting you well to be able to actually, ironically, move into this clinical specialty because you have to look at everything. And so, one of the things that um, is important out of that is the fact that you really are a frontline care provider because when they come into you, sure, they may have vestibular issues or a non-contact, brain injury or whatever it may be, but there's a lot of other things that actually come with that. And that was one of the reasons that I felt it was important, as well as Joe, and all the authors that contributed, that we really focus on the potential for all PTs to be frontline care providers or primary care providers, if you will. So I think that's something that I love, all new PTs to hear, is that they are and can be primary care providers out there on the front line like that. And that generalist is not a bad word. It's a very good word when we're talking about being primary care providers.
Yeah, I think for me, manual therapy is not my strongest suit, right? And I'm totally okay with that because if I have someone that I'm working on or working with who is post concussion, I have so many things to work on that I don't really have time to treat their neck. So what I do need to be able to do is know when their neck is causing the symptoms and refer them to another PT. Just like if a patient needs vision therapy, right? Maybe that's not in your wheelhouse, right? But you can certainly send them to me and then I can help with that. So I think it it helps instill a little bit of humility about the breadth of knowledge that we can have and learn to really work well and understand what another person is going to bring to the table if we invite them.
Yeah, that's such a critical piece because it is so easy to let your ego get in the way and say, "Oh, I can treat that. I can treat that. I can treat that." But the most the best thing that we can do is to say, is to admit whatever our limitation is and go, I know the person that is really good at that because it's not me.
Yes.
you know and sometimes that's not the hard part for I think most clinicians, perhaps, unless they're like brand new and still think they know everything and can do everything. I think the hard part is accessing other resources, of knowing
Mm.
who is that same therapist available. Did they leave the practice? Did they move? Do I have a strong network of of people that I can refer to? I know in my private practice here in Greensboro, I'm constantly working on that spreadsheet, of our providers so that we can actually make the appropriate referrals.
Yeah, that is challenging. I know I do provide a lot of pro bono care in my job where I work now. And so I have to have people that provide free care typically to give the names to my patients. So I think that, and know various and a various sundry of different charitable organizations that can help out when needed. So it is very much a challenge to keep abreast, especially in the traditional healthcare setting, I think, which is not set up. I worked in a clinic at Camp Lajune that if I was working with a patient, and most of the people that I worked with, they had a lot of mental health comorbidities, significant anxiety, depression, or maybe PTSD. And so sometimes people are amenable to things like mental health care. Sometimes they're not. And so for me, I became pretty skilled at talking to people about mental health care and what that meant. And so sometimes during my sessions, they would be like, okay, I'll go talk. And well, will you go talk now? And so I could walk them straight down the hall to a mental health care provider's room, and they could start building rapport with someone. So when they open the window, you've got to have somebody to take them to. And I think the more interdisciplinary clinics that we can have, even as PTs. So I think oftentimes we think of our clinics as either being like, maybe I think about like a CrossFit based clinic or an outpatient neuro clinic or a outpatient orthopedic clinic, right? But in reality, maybe we should just have clinics for human beings. And so there's providers from um, different specialties that work together.
That was always my dream as a baby PT, is to have that interdisciplinary,
Mhm.
interaction, and that it's accessible. And I work in a relatively interdisciplinary situation now, which is good, but it can always be better. And that kind of leads me into my next question. It's one is, how did you start through Pilates? I think was your part of your answer on, um, or part of the answer on how you worked in and came to integrative and lifestyle medicine, because Pilates is certainly a mind body function. Um, but is there any other backstory on, how you became interested in that? And then I have kind of a follow up question after that.
Okay. Well, my story about how I really came to integrative healthcare is probably um, it's a very personal story that I won't go into sharing all of today. But I think for me, I had to investigate my own humanness in very real ways that were not easy. And when I did that, it um, kind of opened me up, I think, to being more inquisitive or curious than I already was about the impact that thoughts and emotions have on the physical manifestation of disease, or that how they limit people's lived ability to live their lives the way they want to, or their willingness or ability to participate in life the way they want to. And that's really kind of what led me to yoga. And then in working with people at Camp Lajune, particularly Marines, I think they taught me more than I deserved to learn. I say they were great lessons and privilege for me because I didn't have to go through what they went through. And they taught me so, so much about the impact that trauma and the lived experience of trauma has on people's well being. And so um, that's where it started. And now I work at a historically Black college and university. And I've heard students share their racialized experiences of trauma. Um, and so that added another layer of privilege for me, where I'm able to hear students of color talk about their lived experience in the world and um, what that's like for them and how they carry that with them everywhere they go and everything they do.
Right. You can't just sit that down and, you know, tackle your Tuesday. It's always with you. And
Yes.
for listeners, that's a little bit of a shared story for Lava and I, because that's how we met, was through yoga and Camp Lejeune, because I was actually at that time living at the coast and teaching yoga as medicine or continuing education. to healthcare providers, and we got involved in what would go on to not happen because, as you might imagine, it's hard to do research in the military. But we started working on preliminarily a research study that would have been on yoga, so integrative and lifestyle medicine at that time. But that's a little bit of our kind of intersection story too. Yeah,
Yeah.
of how we met each other. Um, So out of the I call it ILM for short, Integrative and Lifestyle Medicine. So out of ILM, and we've talked about a lot of topics. So I have 2 or 3 questions kind of backed up against each other in my brain. But the first one would be, you've touched on your background and working with people with trauma, teaching students with trauma. We have concerns about healthcare access and healthcare justice. What would you say that, if you could bring out one important point or 3 important points, however many you want to make from your chapter, what would it be? What would be the big salient points for people?
Well, I think that, okay, I'm going to bring up 2 and I'm going to have you remind me.
Okay.
So one would be inclusivity, and the next would be intensity. So 2 eyes.
Okay.
So I'm going to start with intensity because I think it's simpler. So intensity matters, right? That's a principle that the neurology section of the APTA has blasted a lot, and it's really important. But typically it's spun more towards high intensity. And high intensity exercise is appropriate in the most thoughtful and evidence-based prescription model for different populations. So for example, people with Parkinson's disease, moderate to high intensity exercise, the higher intensity, the better, is what is best for them if they can successfully do it. For people post-stroke, high intensity stepping is really, really important once they're stable. But there are other populations where intensity has to go the opposite direction to start with. Or maybe, for example, concussion. So when people are post-concussion and they're working back to return to sport, we start with lower intensity exercise to let their nervous system kind of settle in again.
Can you,
The same,
oh, sorry.
go ahead.
For the person post concussion, what might that look like for them when you say, you're backing it up and the intensity goes the other direction? Because I think for a lot of people, this might be the first time that they've heard this. Oh, I should do less in this population instead of more. So what would that look like for that person?
Yeah, so it depends on what their impairments are. If someone comes to me and they have a lot of oculomotor deficits, and maybe they have some cervical spine issues, and they also have exertional headaches, then I oftentimes will start them on the bike and we'll have them maybe start at like 60 to 65, 70% of their age-adjusted heart rate max. So that's largely based upon the DivBit guidelines is what I used a lot. There's also the Buffalo concussion tests that you can use to prescribe a more specific dosage as well. And then you can kind of walk them up step by step. So once people's oculomotor skills or their cervical spine gets better, then we might move up to the elliptical and keep the heart rate range the same so that we know if they have symptoms, whether it's likely from the oculomotor system or the neck as compared to an autonomic issue. So there's kind of this piecing apart as they move up, but eventually we want them to get up to as high intensity as they can. It just takes a little more time to walk them through it. And I think one of the things that I didn't touch on in the chapter was this diagnosis called 3PD, which is kind of, I guess it stemmed from chronic subjective dizziness, where essentially, I'm going to oversimplify this a lot, but the brain interprets an traumatic episode of dizziness, even BPPV sometimes, in almost a trauma way. And so, because dizziness is very alarming to adults,
Mm-hmm.
it's a very alarming symptom. So with that population, we want to especially if there's trauma or mental health issues involved, we want to kind of create a container where people feel safe to progress through these areas that have been hard for them. And I think that's one of the places that we can really be skillful, is thinking about how to really thoughtfully and intentionally prescribe physical activity. And then also to carry the ILM further, understanding things that are outside factors that are limiting their ability to be physically active. So those things might be diet, they might be sleep, might be a really big one, especially with the post-concussion and trauma folks. So understanding how those areas fit in, and the need to either get people to the right provider or to make sure that you're giving them strategies to help them sleep better at night, or coaching them on things to eat to help control their headaches, especially if they're having migraines, can be beneficial. And then I think, go ahead, Ginger. You look like you were going to ask a
Oh,
question.
go ahead and finish your thought. I have a follow-up. Yeah.
Okay. So I was going to go next kind of into this inclusivity piece.
Oh,
But do you
well,
want to ask something
yeah,
else
yeah.
before we
I
go
have a
there?
question
Okay.
on that, because I think for a lot of people, they might want to understand and know, especially if, let's just say, you're in the orthopedic, you know, space, and you have someone come in, and you know how people forget to put stuff on their intake. Oh
Yes.
yeah, I have a cervical fusion, forgot to tell you, you know.
Yes.
Or I had a stroke last year, just forgot to tell you. Or I had COVID and was intensive care, forgot to tell you, kind of thing. So if someone comes in with autonomic symptoms or oculomotor symptoms, what is that going to look and present like to you, so that either PTs, or if you're a person listening, you know, oh, okay, those are red flags that I should seek out care for.
So people with oculomotor problems may report problems reading. So maybe when they're reading, they may have problems like staying on the same line, or maybe when they look at the page, they see words kind of bouncing, or things, it's really hard for them to, for the focus, to use their focusing mechanism. So they see things kind of go in and out of focus a lot. I think, especially with young people, those might be things that would be telltale issues. With older adults, it could manifest in lots of ways. So it could look like balance and fall problems. It could look like, maybe they feel like they're not driving as well. And I think it might be harder to find in an older adult population. And some of this, I think they might be less likely to report it. So what I tell my student group is that if somebody has a cervical injury, consider doing an oculomotor exam and seeing if they have symptoms with it. And if they do have symptoms with it, then make sure that you're pursuing appropriate care. As far as autonomics, I think it could go a lot of different ways. So from a concussion perspective, people may get headaches or dizziness with relatively low levels of exertion. They may also, people with Parkinson's disease may report lightheadedness when they're getting in and out of bed. So that can be another really common thing for older adults. So making sure that you're checking vitals, I think, is really important also. And if someone, I think the key is also believe your patients. So when they tell you, I know as a new grad, that was something that was hard for me, and all the time. And it's something that I've really had to, because I have my areas of cognitive dissonance like everyone else, right? Where I kind of just follow the path of least resistance. And I think believing your patients and understanding that oftentimes it's not their fault. We just don't know enough yet. And that's okay, right? It's okay as a provider to not know the answer and to kind of have to sit humbly in the space of discomfort and rely on other people and talk to other mentors that you have or colleagues, and just get other ideas for things that you can do, or even call the physician if they have a really great physician.
That's such an important point to make, is that, you know, creating that safe space. It's one of the softer aspects we don't often think of as new graduates or new practicing PTs, because you think I think you see things as black and white. You're mostly worried about differential diagnosis, but oftentimes what you have to worry about the most is, am I creating a safe space and really listening, deeply listening to patients and earning their trust so that they'll trust me, us, as a profession, that we are able to help them, and that maybe most important, that we're imparting to them that sense of control and self-efficacy, that that they can be better, that they can get better.
Yeah. And
Yeah.
I think that's a great segue into inclusivity,
To
right?
inclusivity.
Because
Yeah.
yes, because that's part of creating a safe space. So, um, Ginger and I were talking, or Dr. Garner, but we're talking before this. And um, one of the things we were talking about is the need for inclusive clinical environments. And so if I think about the majority of clinics that I've worked in, very few clinics have bariatric equipment for like new steps or lower body ergometers for people to exercise on that are not maybe a normal body weight. And so when people come into a clinic and that's the space that they're in, they may be much less likely to return because just the space itself is not inclusive. And then if they don't see people who look like them, or that they feel like they can talk to, receptive, that can be receptive to their medical concerns, then it makes it even worse. So it's important, as we represent our companies, that we're and our organizations, that we're putting forth a multitude of face and body types that come from all kinds of backgrounds, so that we're really welcoming in all people, because all people deserve access to healthcare. And when I think about where I work now in East Winston, many people don't have access to green areas or green spaces where they can engage in physical activity. They may not have the financial means to pay for a gym membership. So even for them, getting in lifestyle physical activity of taking 10,000 steps a day could be a real challenge for them to feel safe to do that. Where I grew up is farm country. There's no sidewalks, right? I mean, you can maybe get to a park, but you might have to drive a long ways. And if you've ever walked down the side of a country road, it's not typically that safe. Like,
Yeah.
you have to be willing to dive into a ditch pretty quickly.
Mm-hmm.
So, and you may get chased by a dog or two.
Mm-hmm.
So anyhow, I think having inclusive spaces and access to care is a really huge issue. And then having diverse clinicians who can really meet the needs of the diverse population that is really important.
Yeah. It when, as a white female, um, we have that certain amount of privilege that if we don't recognize it, that makes us pretty tone deaf to what's going on in the world. And then as a mother of three, I also realize that by and large, women are often not listened to in healthcare. So there's a certain um, saddling that we have to carry through our lives, knowing if I end up at the ER, if I end up in an appointment, I very well may be medically gaslighted, in some way. So when we think about our own experiences, I think that's one step, is what is your experience? Have you experienced discrimination? How do you want your healthcare experience to look? And seeking providers out that will help with that, or asking people, hey, do you know someone, is important. I think the other part of that is, um, and that's part of this series, is looking at and talking with doctors of physical therapy across realms that are willing to say, hey, I know of a resource, or of someone who can help, because I wish there was a simple solution to solving the healthcare affordability and access problem, but currently it's us kind of in the trenches in our communities doing that outreach and saying, hey, I do a free consult. Doesn't matter if you end up coming and seeing me. I can spend 10 minutes talking to you and pointing you in the right direction or to resources. Um, and the second part of that too is when you're looking for healthcare and imagining what you want your healthcare experience to be like, is everybody has a website now, right? Is going to those websites, and it is diversity, are different body types and skin colors and everything represented when you even go to a website. I would say oftentimes it isn't. And I think that, I often feel convicted of that in many ways too. I want to look at my practices and what I'm doing and in my business, and constantly reevaluate. Am I really being as inclusive as I think that I am, or as I say that I am? One thing that came up for me because of your extensive experience and wisdom in the military healthcare setting is, have any topics come up that, in terms of, inclusion for, I can give one example in the yoga community with military, and that's moving away from using Sanskrit and chanting towards maybe just a simple vocal toning because of some of the triggers that can happen with service members who have served overseas, and using foreign language chanting could very much be a detriment or a trigger to them. So that's one kind of point of accessibility in talking about military service members. But are there others, and not even necessarily in the military, surrounding inclusion of, where you've experienced that and where you see there can be room for improvement?
Yeah. So I know I have been talking in the military environment. I never had, I don't think anyone who was actually concerned about practicing yoga from a like religious standpoint. I think that that has happened more in the civilian world, interestingly.
Mm-hmm.
I, for me, I'm not sure where to go with this. For me, I think that the religious issues people have with yoga has been one of the most challenging. And I just have to step back and say, okay, well, this is not, I don't need to go there, or I need to explain it in a very cut and dry scientific manner.
Mm-hmm.
And so with the military population, a lot of them have experienced some religious trauma, I would say, or moral injury. We'll call it moral injury.
Mm-hmm.
So where they are faced with decisions where there's no real good choice, which is actually really a problem related to, for many healthcare workers today, post COVID, right? This moral injury issue
Mm-hmm.
um, has been a real problem. So I think that I have tried to make things as simple as I can. So I often will liken yoga to just resource management, which is, I think, a great approach for ILM. So when I worked with special operators, they love the game Settlers of Catan. So if there's anyone who plays Settlers of Catan out there, this is oftentimes how I use to explain it to them. So instead of talking about the koshas, which might be the way we would talk about it in a yoga environment, I or I will just talk about it. You come into every day with different resources. So maybe you had a great night's sleep and you feel like you can really get in a good workout and a good day at work. And your relationship's going well with your significant other and your bucket's kind of full. So we have these different resources of sleep, physical activity, and diet and nutrition. And you have to figure out ways, and then family and relationships, and you have to figure out these ways to manage all of these things. And every day, though, it's different. So if you don't sleep as well, then maybe you have to take a break in the middle of your day and give yourself some time to go catch a nap. Sometimes for sleep hygiene, napping can be bad, right? But maybe you have to take a breathing break. Or I taught them in the military Iris Yoga Nidra. And so maybe they take a break and they go do a pre-recorded yoga nidra session in their truck or car while they're on lunch. And that's kind of the way I kind of worked to navigate away from talking about any kind of religious undertones. I would really steer away
Mhm.
from that and just focus on it as a way to thoughtfully and mindfully gain some control over the resources that you have or don't have on a daily basis.
I think that's such a brilliant way of action. The just the nomenclature that you use, just that vernacular of resource utilization, you know, and you can put it in the bucket of all the integrative and lifestyle medicine stuff. So we have mindfulness, which can be different than meditation. You have yoga, which can be different from mindfulness. You have Pilates or Tai Chi or Qigong, and then you've got sleep, nutrition, stress management, you know, physical activity, environmental influences, all of those things. And if we listed them all at once, it can feel overwhelming. But when you talk about them in terms of what resource do you have available to you today, it makes it, it chunks it, it scaffolds it into something that's realistic and doable. And that's really where it's at, is behavior, you know, change and managing our own behavior and saying, I have 5 minutes, what resource will I choose today? You know.
Yes.
Yeah.
Yes, because in the end, really, I think what every person is after is living the fullest expression of their life.
Mm.
It doesn't matter what background you come from. And so, regardless of my background, I can put my biases aside and say, I am, it's my privilege, right, to walk with you on this journey to you being the best version of yourself that you can be. And so, let's just talk through how you might encounter obstacles in your day, and then how you might think about the resources that you commonly have in place that you might use to overcome them.
That's a perfect ending. It is. I could not have summed that up any better.
Oh, thanks.
Yeah, thank you so much for spending this time talking about a lot of important things. Neurology very much requires a holistic, whole person, integrative approach. And you could make an argument in all kinds of populations, but you know, when since the nervous system controls so much of who we are, I think that that just encapsulates, you know, it perfectly. So thank you.
Yes. Yeah, thank you.
Yeah. All right, guys. Until next time. Keep on keeping on in whatever resource you're going to pull from today, whether it is good sleep or grabbing a glass of water and staying well hydrated, or taking a mini break, you know, during your lunch just for mindfulness, or to take a short walk. And we will see you next time.